Welcome to the Hospital Medicine Unplugged podcast.
It's good to be here. Today, we're going to be doing a deep dive into a clinical problem that is not just ubiquitous, but also pretty insidious in its impact: anemia in the hospitalized patient.
It truly is. And this isn't just some benign lab value we can passively trend. I mean, it's a real driver of morbidity. The numbers themselves are just arresting. Anemia is so prevalent in the inpatient setting, affecting somewhere between 44% and 67% of patients right on admission.
And that high prevalence comes with very serious clinical consequences. The data, it consistently shows that the presence of anemia significantly impacts outcomes.
Oh, so?
Well, it drives up the length of stay, it increases readmission rates at both 30 and 90 days, and it elevates the risk of mortality, whether that's in hospital or even in the post-discharge recovery phase.
Right. And when you think about the complexity of our patients, their frailty, their high comorbidity burden anemia just becomes a major risk multiplier.
Absolutely. And the risk is compounded because the very fact of being acutely ill, an infection, a major surgery, inflammation, all of that can worsen existing anemia.
Through what mechanisms?
Well, through things like iatrogenic blood loss from all the frequent phlebotomy, suppressed erythropoiesis, and of course the underlying systemic inflammation itself.
So our mission for this deep dive is to really cut through that noise and focus specifically on differentiating, diagnosing, and then creating targeted management plans for the three most common iron-related etiologies.
That's right. We're talking iron deficiency anemia, anemia of chronic disease or inflammation, and maybe the most challenging of all, the overlap syndromes.
And getting this distinction right is it's the gateway to effective, targeted management that can actually impact the patient's entire trajectory.
Okay, so let's unpack this. I think we should start with the foundational definitions because the distinction between an absolute iron deficiency and a functional one is fundamental to understanding everything else.
I agree. It explains the mechanism, the lab work, and ultimately the treatment approach. So let's start with the one that seems the most straightforward. Pure iron deficiency anemia, IDA.
Right.
When we talk about IDA, we are discussing anemia that results from an absolute deficiency of iron. It means the patient's entire body iron stores are genuinely depleted. There's no iron left in the vaults.
Exactly. The vaults are bare. And this depletion, it has to be traced back to an etiology. For us, in our setting, it's typically due to pretty straightforward causes like chronic blood loss.
Which is incredibly common, whether it's occult GI bleeding or maybe excessive menstrual cycles.
Exactly. Or sometimes it's just inadequate dietary intake or malabsorption from diseases like celiac or maybe a prior bariatric surgery. The basic pathophysiology is pure starvation. There just isn't enough iron available to support normal erythropoietin-driven erythropoiesis.
So the bone marrow is trying to make red cells, but it just doesn't have the building blocks.
It doesn't have the key ingredient. And physiologically, the body reacts to this state of true iron starvation. It tries to scavenge every last available ion.
How does it do that? What mechanism kicks in?
The body basically goes into survival mode. It tries to upregulate every mechanism available to maximize iron absorption and its release. And this response is very clearly reflected in the master regulator of iron homeostasis, hepcidin.
Ah, hepcidin, the key player.
It's a small peptide that's produced by the liver. In pure IDA, because the liver senses these critically low iron stores, hepcidin levels are profoundly suppressed.
And that's the body's desperate attempt to maximize iron release from storage cells and boost intestinal absorption of any iron that passes through.
It's an all systems go signal for iron uptake. It's trying to open all the gates.
Okay, so now let's contrast that intensely with anemia of chronic disease, or ACD, which is often called anemia of inflammation, or AI.
Yeah.
The definition here shifts completely, and this is where I think most of us frequently trip up.
It is. Because here we're dealing with an anemia driven by a functional iron deficiency. And this is the crucial part. The patient might actually have normal or even increased total body iron stores.
So the problem isn't a lack of iron.
No, the problem is that the iron is inaccessible. It's being purposefully sequestered by the immune system in a process that's sometimes called nutritional immunity.
And this almost always occurs in the context of chronic immune activation. So we're thinking of things like chronic infection, active malignancy, or systemic autoimmune diseases like rheumatoid arthritis or lupus.
Right, and the primary drivers of this sequestration are the inflammatory cytokines. This inflammatory state leads to two major issues.
Okay.
One is impaired iron mobilization, and the other is, frequently, a reduced erythropoietin production, or maybe more accurately, a reduced bone marrow responsiveness to erythropoietin.
So hepcidin is the central character again, but in this drama, how do the cytokines turn up the volume on hepcidin?
Hepcidin is absolutely the star of the show in ACDAI. Inflammatory cytokines, most notably interleukin-6, they stimulate the liver, which is the primary producer of hepcidin, to just crank up production dramatically.
And when hepcidin levels are high, it binds to and promotes the degradation of ferritin.
Exactly. And ferritin, just to remind ourselves, is the cellular iron exporter. It's the only gateway iron uses to exit a cell, whether that's an intestinal enterocyte absorbing iron or a macrophage releasing it from its stores.
So if ferritin is the only known iron export protein, its degradation by high hepcidin just results in iron sequestration.
Precisely. The iron is effectively trapped inside the macrophages, the storage cells, and it's also blocked from even entering the body at the enterocytes. The result is iron-restricted erythropoiesis despite the presence of preserved stores.
So you get that classic paradox of low serum iron despite a high ferritin level because the ferritin is just reflecting all that trapped iron inside the cells.
That's the physiological mechanism.
And then, of course, we get to the complex reality we deal with most often in the hospital, the overlap syndromes. This is where a patient who already has that functional iron impairment from chronic inflammation also experiences a true absolute iron deficiency.
Yes, it's not just one or the other. It's both mechanisms stacking up at the same time, creating a really difficult clinical picture.
Can you give us an example?
Sure. Think of a patient with inflammatory bowel disease. That inherently causes ACDAI because of the chronic gut inflammation. Now, if that same patient then develops ongoing subacute GI bleeding, they are superimposing absolute IDA right on top of their existing functional deficit.
That combination just sounds disastrous from a hematologic perspective.
It's the perfect storm. The overlap syndrome, it exacerbates symptoms, it worsens underlying comorbidities like heart failure, which is particularly sensitive to iron levels, and it absolutely increases transfusion requirements.
Why is that?
Because you're fighting iron restriction on two fronts. The body has no stores, and any iron you try to give it or mobilize is being sequestered by the high hepcidin levels that are driven by the inflammation.
So these patients tend to present with more severe and refractory anemia.
They do. That distinction in pathophysiology, absolute deficiency versus functional restriction is so helpful.
It really is. So let's transition to the bedside. How do those underlying pathological differences actually manifest clinically and biochemically? We need to know what to look for when we see the patient and when we interpret the labs.
Okay, let's start with the clinical clues, but we have to acknowledge a major challenge up front. Many symptoms of anemia are just nonspecific. Generalized fatigue, pallor, exertional dyspnea, these apply across the board.
Right. But if we look at IDA first, in addition to that generalized fatigue and pallor, patients might present with a headache, dizziness, tachycardia, or even angina or syncope in very severe, rapidly developing cases where the cardiovascular system just can't compensate.
But the truly specific findings are those linked directly to the iron depletion itself. And these are often more pronounced as the anemia develops quickly or becomes severe. I'm talking about things we learned in medical school but sometimes forget to look for.
Like restless legs syndrome.
Restless leg syndrome, which is very common in IDA. Also pica, that craving for non-food items like ispagophagia or clay. Then there's alopecia, atrophic glossitis, leading to a smooth, painful tongue, dry skin, and the classic, though pretty rare now, koilonychia.
Spoon-shaped brittle nail.
Exactly. If you see those highly specific signs, pica, restless legs, koilonychia, that should immediately put IDEA at the top of your differential, regardless of the initial hemoglobin, because they indicate a long-standing, profound depletion of total body iron stores.
Okay, so what about ACDAI?
ACDAI, on the other hand, is generally much more insidious. It's less symptomatic in terms of unique physical signs. The anemia is usually mild to moderate, typically with a hemoglobin somewhere between 7 and 12 GDL.
And the symptoms?
The symptoms will include fatigue and exercise intolerance, but it's frequently very difficult to disentangle those symptoms from the patient's primary underlying chronic illness.
Right. Is there fatigue from their metastatic cancer or from the associated ACDAI? It's probably both.
Usually both. The physical findings in isolated ACDAI are generally nonspecific. Importantly, while ID is classically microcytic and hypochromic, reflecting those iron-starved red cells, ACDAI is typically normocytic and normochromic.
Though I've seen mild microcytosis if the inflammation is particularly profound or long-standing.
That can happen, yes. And for the overlap syndrome presentation, well, since they're compounded, they tend to present with the most severe anemia symptoms. The clinical picture often reflects the severity of both underlying issues.
So because of the combined effect of absolute iron depletion and functional iron restriction, these patients often have refractory anemia symptoms.
Yes, which leads to a greater burden of morbidity and a higher need for transfusions. If you see severe symptomatic anemia in a patient with a known chronic inflammatory disease, you have to suspect the overlap. You can't just write it off as just anemia of chronic disease.
That leads us perfectly to the laboratory differentiation, which is the absolute minefield where we commonly trip up, especially when inflammation is complicating the picture.
Agreed. We have to stop interpreting ferritin in isolation. The simple mantra of low ferritin equals iron deficiency just fails miserably in the hospital environment where inflammation is rampant.
It really does. So let's start with the measure that causes the most confusion, serum ferritin. In pure idea, what do we see?
In pure ID, ferritin is universally low. We're looking for a threshold typically less than 30 nanograms per milliliter, and anything less than 15 is highly specific for iron deficiency.
And the rationale is simple and direct. Ferritin is the main storage protein, so low levels mean depleted body iron stores.
But in ACDAI, that measure becomes completely unreliable as a marker of iron availability. Ferritin is a positive acute phase reactant.
So in the presence of systemic inflammation driven by those interleukins, especially IL-6, the production of ferritin by the liver is dramatically upregulated.
Correct. Therefore, the ferritin level will be normal or often high. The rationale is that even though the iron is biologically unavailable for red blood cell production, the stores are preserved, and the inflammation elevates that baseline storage level. It often pushes it into the normal range, or even above 100 ng/ml.
This is the primary hurdle for clinicians. If you have an inflammatory patient, say someone with sepsis or a complicated post-op course and their ferritin is 80, you might reflexively dismiss IDA, but that's a dangerous omission.
A very dangerous omission. Let's move to transferrin saturation, or TSAT. How does this critical ratio behave?
TSAT is the ratio of serum iron to the total iron binding capacity, or TIBC. In both pure IDEA and ACDI, TSAT is typically low, right? Often less than 20%.
Yes, that's a consistent finding. And here's the crucial rationale. TSAT reflects the iron that's available in the plasma. Whether that iron is low because the stores are exhausted, like in IDA, or because iron release into the plasma is restricted by high hepcidin, like in ACDAI.
The percentage of circulating transferrin carrying iron is restricted, so it's low in both scenarios.
Exactly. A low TSAT means the iron delivery truck is running on empty, regardless of why.
That helps clarify why TSA is such a consistent indicator of iron-restricted erythropoiesis. Now, what about serum transferrin itself, which we often measure as TIBC?
That gives us another clue. In IDEA, serum transferrin is high, or the TIBC is elevated. This reflects the body trying desperately to compensate by increasing its binding capacity. It's making more transport vehicles to scoop up any available iron.
Whereas in ACDAI, transferrin levels are usually low or normal. And this is another key insight into the effect of inflammation.
Right. Inflammation actually decreases the liver's production of transferrin, resulting in a decreased total binding capacity. This is a key differentiating factor from pure IDA. The liver is prioritizing acute phase reactants, like ferritin, over transport proteins like transferrin.
Okay, this is where it gets really interesting and where we find the adjunctive biomarkers that can act as tiebreakers. Let's talk about soluble transferrin receptor, or sTfR.
In IDA, sTfR is high. What's happening physiologically there?
The sTfR is basically a cleavage product of the transferrin receptor found on the surface of most cells, especially those in the bone marrow making red cells. When cells are starved for iron, as in IDA, they upregulate the expression of the transferrin receptor on their surface, trying to pull in more iron.
And this increased production leads to more cleavage and therefore high circulating levels of sTfR. It reflects that increased cellular iron demand.
But the key discriminator, and why sTfR is so valuable in the hospital, is that sTfR levels are normal in isolated ACDAI.
Precisely. And the reason is because sTfR is not an acute phase reactant. Its levels aren't artificially elevated by systemic inflammation.
So if you have a patient with active inflammation and a low TSAT, but their ferritin is, say, 90 ng/ml, an elevated sTfR would strongly point toward a coexisting absolute iron deficiency, the overlap syndrome.
It bypasses the confounding effect of that high ferritin. It has immense discriminatory value.
And just to round it out, serum iron itself is low in both conditions. And hepcidin, though not routinely measured, is the ultimate difference maker. Low in IDEA, high in ACDAI.
And finally, looking at the basic blood smear and indices, the CBC usually shows that classic microcytic hypochromic anemia in IDA.
Small pale cells.
Right. And in ACDAI, we typically see normocytic normochromic anemia, though, as you said, mild microcytosis can occur.
The reticulocyte hemoglobin content is also a practical distinction. It's low in IDA because the developing red cells are truly iron-starved, but it's often normal in isolated ACDAI. A retic HB content less than 28 picograms is a strong predictor of iron-restricted erythropoiesis.
So when we connect all these data points, it just underscores the need for a sophisticated, nuanced diagnostic approach that goes way beyond looking at just the hemoglobin and ferritin levels.
Absolutely. So let's shift gears and focus on the practical steps and accepted guidelines for investigation. We really need to focus on how we navigate that complicated ferritin environment in the acutely ill patient, because this is where management decisions often get delayed or misdirected.
The initial workup should be standardized for any anemic patient. A CBC with red cell indices, a reticulocyte count, a peripheral blood smear, and a full iron panel ferritin, serum iron, TIBC, and TSAT.
Okay, let's confront the ferritin dilemma head-on using established guidelines. The American Gastroenterological Association, the AGA, provides clear thresholds, but they have to be interpreted in context. For pure IDA in a non-inflammatory setting, the AGA recommends a cutoff of less than 45 nanograms per milliliter.
And that cutoff works well for an otherwise healthy individual. But this is the crucial caveat for us as hospitalists. If you have a patient with clear chronic inflammation, severe infection, metastatic malignancy, active IBD, their ferritin can be falsely elevated.
Right, because of the acute phase response.
So in this context of ACDAI, or overlap syndrome, iron deficiency may still be present if that ferritin is less than 100 nanograms per milliliter.
This means we're essentially applying a much higher ceiling for what constitutes iron deficiency when we know inflammation is present. Let's run a quick hypothetical to solidify this.
Sure. Imagine two patients, both with a hemoglobin of 9.0 and a TSA of 15%. Patient A is a healthy 30-year-old female with heavy menses. Her CRP is 1. Her ferritin is 40. That's clear IDA.
Sure.
Patient B is a 65-year-old male admitted with a severe COPD exacerbation on steroids. His CRP is 150. His ferritin is 80. If we only use that 45 NGML cutoff, we completely miss the diagnosis in patient B.
But because patient B has a ferritin below 100, combined with that low TSAT of 15% confirming iron restriction in the circulation, we should proceed with management for iron deficiency, acknowledging the overlap syndrome is highly likely, even with a seemingly normal ferritin.
Correct. The key is to interpret ferritin in the context of inflammatory markers. That's why measuring a C-reactive protein or an ESR is absolutely necessary. You need them to confirm the inflammatory state that could be elevating the ferritin.
And the TSAT of less than 20% remains a critical, reliable marker. It supports iron restriction whether the ferritin is 40 or 95.
Exactly. And as we discussed, adjunctive biomarkers like sTfR can offer strong discriminatory value, particularly in that overlap scenario.
So diagnosis doesn't stop at the lab values, especially for IDA. For any patient with confirmed or suspected IDA, the diagnosis mandates a thorough evaluation for the underlying cause, especially occult blood loss or malignancy.
This is a non-negotiable step. The AGA recommendations are very specific here. Bidirectional endoscopy and EGD and colonoscopy is recommended in all men and postmenopausal women who present with IDA.
And that investigation should proceed unless there's a clear, documented, and treatable etiology already identified. We're looking for ulcers, upper GI lesions, and critically colorectal malignancy.
We absolutely have to avoid diagnostic inertia in these high-risk groups. A diagnosis of IDA is a symptom, not a cause, and it's a red flag for occult malignancy until you prove otherwise.
What about for premenopausal women and younger patients?
For them, the need for endoscopy should be individualized. If their anemia is easily explained by heavy menses and it resolves quickly with oral iron, immediate endoscopy might be deferred.
But if the anemia is unexplained, recurrent, or if they have GI symptoms or a family history of colorectal cancer, then endoscopy has to be pursued aggressively.
Correct. And beyond direct imaging, what about non-invasive testing?
Screening for Helicobacter pylori and celiac disease is indicated in pretty much all IDA patients. Both are common, treatable causes of iron deficiency.
Yes. H. pylori can cause chronic blood loss from gastritis or ulcers, and celiac disease causes iron malabsorption. Finding and treating them is highly satisfying because it often cures the anemia.
And if the initial EGD and colonoscopy are negative, but the anemia is severe or recurrent, we have to keep looking.
That's when we consider small bowel evaluation. This usually involves video capsule endoscopy to look for obscure bleeding sources, or potentially a deep enteroscopy if we suspect a lesion that needs a tissue diagnosis.
We're hunting for things like obscure angiodysplasias or small bowel ulcers.
Exactly. And finally, the historical gold standard.
Bone marrow iron staining.
Yes. While it's historically definitive, it's generally reserved for very complex refractory cases where non-invasive studies are completely inconclusive. Given its invasiveness and the high utility of biomarkers like sTfR, it's rarely needed in routine practice today.
And we should remember to screen for hemoglobinopathies with hemoglobin electrophoresis in patients with microcytosis and an appropriate ethnic background to make sure we aren't misdiagnosing thalassemia trait.
A critical pitfall to avoid.
So we've defined the types, and we know how to diagnose them. But what does this all mean for the patient sitting in the hospital bed? Why does this granular diagnosis matter?
It matters tremendously because anemia, regardless of the specific etiology, is consistently associated with universally worse clinical outcomes in hospitalized patients. This is robust data. Increased length of stay, higher readmission rates, and elevated mortality risk, both in hospital and post-discharge.
And the severity of that anemia correlates directly with the magnitude of the risk. The danger rises exponentially as the hemoglobin drops below 10, especially in older adults and frail patients.
Exactly. IDA has its own unique implications. Diagnosing it often signals occult blood loss or a potential malignancy, which requires a prompt, sometimes urgent, investigation.
And beyond the cause, IDA itself contributes directly to adverse physiologic events. It decreases oxygen carrying capacity, puts immediate strain on the heart, and can lead to cardiac decompensation or exacerbate existing heart failure.
Absolutely. And ACDAI, while often less severe in terms of the hemoglobin drop, really reflects the intensity of the underlying disease. A hemoglobin of 9 in a young person might be well tolerated. But in a patient with multi-system organ dysfunction, even that mild to moderate anemia can significantly impair their functional status and quality of life.
It worsens outcomes in major chronic illnesses like heart failure, CKD, and cancer by adding to their overall inflammatory burden.
And if we look at the overlap syndrome again, these patients are unequivocally at the highest risk for poor outcomes. They're dealing with the combined impact of absolute iron depletion, which starves the bone marrow, and functional iron restriction from inflammation, which blocks iron delivery.
And this is often complicated by diagnostic delays because the lab picture is so murky and contradictory.
Exactly. So they suffer from the cardiovascular risks of ADI and the poor functional status risks of ACDII at the same time.
So it sounds like treating the underlying disease is always the priority in ACDAI, but once we have the diagnosis confirmed, pure IDEA, pure ACDAI, or the overlap, what are the tailored evidence-based management strategies we should employ?
Well, the general principles of patient blood management, or PBM, are foundational. This means minimizing iatrogenic blood loss from frequent lab draws. We have to advocate for microcontainers and coordinated draws.
And we must stick strictly to restrictive transfusion thresholds, reserving transfusion for when it's truly life-threatening or when high-risk comorbidities demand it. A hemoglobin less than 7 or 8, or a patient symptomatic with an acute coronary syndrome.
Right. Transfusion is a temporary Band-Aid, not a cure for chronic anemia.
So moving to pure IDA management, oral iron is still the standard first-line therapy.
Right. It is, but it's only effective after we've successfully identified and corrected the underlying cause. If you don't fix the leak, you can't fill the bucket.
And there's been key research that's refined the dosing strategy for oral iron. Many of us were trained to give high-dose iron 3 times a day, which had terrible tolerability.
That's changed. We should be optimizing dosing by recommending every other day dosing of 100 to 200 milligrams of elemental iron. This schedule, or even once daily, has been shown to improve both absorption and critically tolerability.
It reduces the GI side effects like constipation and nausea that lead to non-adherence.
It does, and the rationale is fascinating. High doses of iron can transiently increase hepcidin production, even in IDA, which then blocks absorption of the next dose. Giving it every other day lets the hepcidin levels fall again, maximizing uptake.
That is a crucial practice change. When do we skip oral iron and go straight to intravenous iron for IDA?
5E iron is indicated for several specific scenarios. These include documented intolerance to oral iron, malabsorption syndromes like IBD, significant ongoing blood loss that oral iron can't keep up with, or in high-risk conditions like heart failure, where rapid repletion is medically necessary.
Okay, now let's pivot to treating pure ACDAI. Since this is an anemia of inflammation, the primary focus has to be on managing the underlying disease.
That's the cornerstone. Successful treatment of the infection, the autoimmune flare, or the malignancy is often the only way to resolve the underlying iron restriction. If you lower IL-6, you lower hepcidin.
But iron supplementation here is tricky, especially the route. Why is 5e iron preferred over oral in ACDAI?
Well, if we suspect iron deficiency coexists, which it often does, or if oral iron is ineffective, IV iron is generally preferred. This is because oral iron absorption is inherently impaired due to the high hepcidin levels.
Hepcidin locks the enterocytes shut, making oral delivery pretty much futile.
Exactly. 4-iron bypasses that intestinal roadblock entirely, delivering iron directly into the circulation where it can hopefully be utilized by the bone marrow.
What about erythropoiesis-stimulating agents, ESAs? They seem like a logical step.
They can be used selectively, typically in CKD or certain cancer treatments, but their effectiveness in ACDAI is often limited by the chronic inflammation. The inflammation makes the bone marrow resistant to the ESA signal.
So you're shouting at the marrow, but it's not listening effectively.
Pretty much. They're often reserved for cases where the hemoglobin is persistently very low, less than 10, and iron repletion has already failed.
This brings us back to the overlap syndromes idea plus ACDI. They're the most severe and need the most aggressive approach.
Because the pathology is multifactorial and includes that profound functional deficiency from high hepcidin, IV iron is the mandatory preferred route for repletion. Giving oral iron is often an exercise in futility.
You need to rapidly restore the depleted stores and overcome the functional block at the same time.
Exactly. And the therapy is often highly individualized. It frequently involves a combination of 5e iron with ESAs, particularly if the anemia is severe and unresponsive to iron alone. You have to ensure the patient is fully iron replete before starting ESAs, though.
We should pause for a critical safety note about iron therapy, especially IV iron, in the acutely ill patient.
Yes, safety is paramount. Monitoring for infection risk is essential. Free, non-transferrin-bound iron can promote microbial growth, especially with an active bacterial infection.
So, while IV iron is highly effective, it needs to be used cautiously in hospitalized patients who are prone to infections.
It does. It requires clinical judgment based on the severity of the infection versus the urgency of repletion.
Let's discuss some nuances in specific high-risk cohorts we frequently see. For patients with chronic inflammatory diseases, heart failure, CKD, IBD, cancer functional deficiency is the rule, not the exception.
Yes, and this reinforces those tailored diagnostic thresholds we discussed. In these cohorts, you should be using a ferritin cutoff of less than 100 nanograms per milliliter and/or a TSAT less than 20% to diagnose iron deficiency.
And that diagnosis is highly prognostic for poor outcomes, especially in heart failure.
It is, and given the chronic hepcidin-driven restriction, IV iron is strongly preferred for both repletion and maintenance therapy in these groups. The FAIR-HF and CONFIRM-HF trials show that IV iron in heart failure patients improved exercise capacity and quality of life, even without severe anemia.
A powerful finding. What about pregnant women?
IDA is highly prevalent in pregnancy, especially in the third trimester. Oral iron is first line initially, but if it fails or isn't tolerated, IV iron is recommended in the second and third trimesters to achieve rapid repletion and avoid complications.
And finally, older adults. A highly complex group where diagnostic inertia is a huge problem.
Anemia in older adults is almost always multifactorial. You have to prioritize excluding occult blood loss, nutritional deficiencies, and chronic disease. And IV iron is often used when oral therapy is challenging.
And a key point is avoiding what the literature calls replacement inertia, delaying investigation and treatment just because the patient is old or frail.
Absolutely. This must be avoided as anemia significantly increases frailty, sarcopenia, and functional decline in this population. Treating the iron deficiency can lead to measurable improvements in strength and even cognitive function.
And looking forward, long-term follow-up is essential to prevent recurrence.
Yes, regular follow-up every 3 to 6 months to reassess the CBC, radic count, and iron parameters ferritin and TSAT. The radic count is especially helpful 1 to 2 weeks after starting therapy to confirm a good response.
And for patients with ongoing risks, like active IBD,
Maintenance iron therapy, whether oral or scheduled for, may be required to prevent the stores from becoming depleted again.
for the most complex refractory cases, what resources should we rely on?
Multidisciplinary management is key. Input from gastroenterology, hematology, and nutrition is often advised to optimize the treatment plan.
Okay, let's wrap up by discussing what's coming down the pipeline. It's clear that our current strategies are limited by that hepcidin barrier.
Indeed, the future of anemia treatment is focused specifically on targeting that underlying pathophysiology. If we can control hepcidin, we can fundamentally change how we treat ACDI.
The first major area of research is targeting hepcidin itself.
Yes, hepcidin antagonists and modulators. They're designed to either lower hepcidin production or block its action on ferroportin, thereby releasing the iron trapped in macrophages.
So they would essentially reverse the functional deficiency of ACDAI.
That's the goal.
Yeah.
But they're still in early trials and not yet standard of care, though they hold immense promise.
And the second exciting area involves enhancing erythropoiesis directly.
Right, with hypoxia-inducible factor prolyl hydroxylase inhibitors, or HIF-PHIs. These agents stabilize HIF proteins, which mimics a chronic hypoxic state.
And that stimulates endogenous erythropoietin production and improves iron metabolism.
It does. They're already used in CKD, but their potential for broader use in anemia of inflammation is being actively investigated.
What are the main concerns with HIF-PHIs right now?
Long-term safety and potential cardiovascular risk are the primary concerns. We need more robust data on thrombosis, malignancy progression, and cardiovascular events before they become standard frontline therapy outside of CKD.
This deep dive has really highlighted the essential difference between absolute and functional iron deficiency and the compounding risk they pose in the hospital. We've moved far past just reading a low hemoglobin number.
We have. We covered that ID is defined by absolute depletion, low ferritin, high transferrin, and requires treating the underlying cause first. ACDAI is driven by inflammation, normal or high ferrit, low TSAT, high hepcidin, and requires treating the underlying disease, often with IV iron.
And the overlap syndrome, which is so common on our wards, demands the highest vigilance, often requiring IV iron and sometimes ESAs. The critical, practical takeaway for our peers is the absolute necessity of using that higher ferritin threshold, less than 100, and the low TSD, less than 20%, to diagnose iron deficiency in the face of inflammation.
The emphasis remains on early, nuanced diagnosis, aggressive etiologic evaluation, especially for GI malignancy in men and postmenopausal women, and tailored therapy, favoring 5E iron when chronic inflammation is present to bypass the hepcidin blockade.
So let's leave our listeners with this final provocative thought for their professional contemplation. Given that anemia in hospitalized patients consistently predicts worse clinical outcomes and that hepcidin is the master regulator blocking iron utilization, what impact will the next generation of hepcidin-targeting therapies have on standardizing our restrictive transfusion practices and fundamentally changing inpatient morbidity? Will these targeted agents allow us to treat ACDAI as aggressively as we treat IDA today, and what systemic effects will that have on hospital length of stay and readmission rates?